What's the difference between being a primary care network pharmacist and a GP pharmacist?
Yeah, I think my answer is quite short, which is nothing. If you, and I say that, if you understand that your job has to be split in an operational and a strategic way. So if I think some of the difficulties where pharmacy professionals moving into primary care, or primary care thinking that the pharmacy professionals they've employed are not working out for them, is because both sides misunderstand, as I've just described, about how long it takes to understand. I mean, the computer systems in primary care are phenomenal compared with secondary care, but I reckon it took me 2 years to fully understand it. It can do so much stuff, and there are so many things that you need to be aware of in relation to the use of medicines. It is incredibly complex. So it actually is not that much different if you just think in a wider sense, because instead of when I started, it was just maybe 20,000 patients in one practice. Now I've got 3 practices, 40,000 patients. So I suppose from my background, it was just a question of thinking bigger. So again, going back to the strategic and operational, I know nobody likes to put figures on stuff, but I love the 80-20 rule. I think you can apply the 80-20 rule to everything in life. And I would say, you want to be doing at least 20% of your time involves strategic and 80% operational.
Thank you. My next question is, how can a PCN work out what kind of pharmacy input it needs? How many pharmacists, how many technicians, and what they should be doing?
We're in 2021 in the middle of a world pandemic. And even before we went into the pandemic, and we've talked about how, yes, it's a very attractive proposition to come and work in primary care, whether you're a pharmacy technician or a clinical pharmacist. So my answer to this is really quite blunt. How many do we need? Well, the rate limiting step is the workforce in the area. So what is happening is we are at risk of sucking people out of secondary care and community pharmacy into what looks like a new and shiny role that has lots of opportunity, don't have to work at weekends, don't have to do on call. And that's going to break us. So I actually feel very strongly about this. And luckily I've managed the PCN that I work in, Poole and Bournemouth, has understood this. And so we are very clear that we want to have the right, as many people as we think we could utilize, but realizing that if we just suck people out from one area, that's going to destabilize the whole system. So whilst I told you that we've got 2 pharmacists, 2.5 whole-time equivalents, and 2 pharmacy technicians, half of those are employed not directly through the PCN, but we work in conjunction with our colleagues. So we have people who are employed by the Community Health Trust, who might do half their time for us, but half their time working for the Community Health Trust. We have a pharmacist who's about to start, who's going to work partly in a community pharmacy and partly for us. So we believe that for a sustainable system within the integrated care system in which we work in, that's the way that we need to work. And I, again, feel very strongly that also gives job enrichment. So for pharmacy professionals, you need job enrichment, otherwise you don't stick around, do you? So, but it has to be sustainable for the integrated care system. So the answer is, you could, the rate limiting step is workforce and what you've got. And the second thing I would say is that you need to have somebody who is, if you like, the senior pharmacy professional in the primary care network, who has enough experience, whether they've come from hospital or community or anywhere else. They need to have enough experience in how to influence people, know and understand about systems and change management, and be able to quite quickly get clinical trust from their clinical peers within the practice and primary care network. Otherwise, it's going to be a massively uphill struggle. And all the things that I hear about where things haven't worked out in practices and primary care networks is because there's a disconnect. And so that does mean that if you're a primary care network, you have to remunerate appropriately, but you don't take or pay them if they don't have the experience, but they need to not just have the clinical experience, they need to have the ability to manage people influence others, have strategic vision and clinical leadership. And I think that is the key, not numbers of people in a PCN, but the right people in a PCN.
Oh, those are very useful insights. So what are the next steps for you?
I love my job. I've spent 30 years working in the NHS and I love what I do. And so I think, though, that what I really want to do is to be able to help other practices and PCNs who need a bit more leadership. That's the one thing that I think I can give most to a greater proportion of communities and to a greater proportion of mentoring and supporting others, because it is a tough job. And I'm lucky, I said at the beginning, I feel privileged because I've been well trained by the NHS. I have a lot of training behind me. So, whilst it might appear that I have thought about what the role is, that's from 30 years of doing it and failing and realizing that I need to do it like this. So that's the one thing I think I'd like to try and do.
And finally, do you have a message for your colleagues in primary care, other healthcare professionals working in primary care?
I think what I say, and I've written a few documents, I've written a few papers with Dr. Lawrence Brad, who's my sort of GP prescribing lead who employed me, and he and I do a lot of thinking and talking and writing for journals, and he's also very well connected with the Royal College of GP. So I'm very lucky that he and the PCN I work for support my vision, and I'm still well connected. So, for example, I was sat on the overprescribing report recently with Keith Ridge. So I have the ability, hopefully, to influence. So I suppose what I would say is that, look, we all know that medicines is still the #1 intervention used in healthcare. It's huge. There are huge potential problems ahead in relation to people getting older, more and more medicines, more and more conditions, and we need to manage that. And so pharmacy professionals working in primary care are an absolute necessity. They're not a luxury, they're a necessity. And the optimal use of medicines is important for the health and well-being of all people within the community in which they work. And so I have this final view about problematic polypharmacy, which drives a lot of what I do, which is, look, if we just keep adding medicines and never subtracting, we multiply the problems. That is what I'm trying to sort.
Steve Williams, thank you very much for sharing your experiences and insights with us today. There is much food for thought there. For more information about Steve Williams' work as a primary care network pharmacist, please visit our website using the link in the description. And be sure to sign up for more news, videos, and journals. For updates straight to your inbox, please sign up using the link below. And as always, thanks for watching.